Office, Kochi. I'm hoping that you can all hear me, and thank you for joining us today. Okay, so we can start off our discussion today. Yeah.
I hope everybody can hear me. I'm Dr. Amitabh, and this is our first webinar, and this will be the series of webinars we'll be having every month. And hopefully everybody can hear us. And if you have any questions, you can just put your questions in the chat box and keep your microphones in the off mode. And you can just send your questions in the chat box, and we will try to address those questions through that. So we'll start off the presentations now, and I'm handing over to Shri Lakshmi.
Okay, so we have designed the discussion in such a way that we will pause in between the slides so that we can have an interactive session. We'll be checking the chat box in between, and we'll try to make it as interactive, as informative as possible. And you can, there's an option of raising hand symbol, and we can get back to you once that's done. So shall we start? We'll start.
Yes.
Okay, so good evening, everyone, and welcome to our session of Airway Challenge in Cardiac Operating Room. This is a discussion on a case we did in December 2019. It was but the baby initially came to us in August 2019. He presented to us when he was 4 months old. He was 3.6 kgs in weight, and he was primarily referred from outside for a VSD closure. He was a pretermer with a birth weight of 1.7 kgs, born to a diabetic mother via He had a history of 1 week NICU stay in a peripheral hospital, 3 days of ventilation, after which he was extubated successfully, and he was diagnosed VSD during the NICU stay. When we received him at 4 months, he had the mother had given a clear history of persistent noisy breathing with the typical suck-rest-suck cycle and failure to gain weight. For the persistent noisy breathing, an ENT evaluation was done in the outside hospital, which said there was no significant finding. In physical examination, the child looked alert, playful. Although he had a tracheal tug, but mild subcostal retractions, we didn't think he didn't look like as if he was in a major distress at that time. And there was no sign of active infection. Chest was clear. We got a grade 3 pansystolic mum at the left sternal border. So we decided to go ahead with the surgery. On the day of surgery, we were encountered with this major problem. We were not able to intubate the child with an age-appropriate tube. We were able to admit only a 3 mm uncuffed tube, and we had to fix it at 8 because we were not able to negotiate the trachea beyond 8 centimeters, and he had a concomitant compromised ventilation. So this is now over to the viewers. Now I would like to take in inputs from you. What should be the next course of action, and should we proceed with the surgery or no? I would like to know your inputs on this.
Yeah, Shri Lakshmi.
Can we have it? Can we have your opinion in a chat if possible, please? Because hello, doctor. Can you introduce yourself, please, and we'll take your opinion.
Dr. Jigar, you can just type it off. Just type it in the chat box.
I'll send it.
Okay, got it.
All right.
Tracheal tug by no other investigation.
Yeah, so the baby had a tracheal tug. The thing is, like when we do VSDs very routinely, and we get tracheal tugs for lots of our babies, and but this didn't seem very severe when we saw him, and we kind of underestimated his problem actually. Yes. And an ENT evaluation was done, which was just not done in our hospital, and we didn't want to repeat the same investigations, which is why we thought, let's just go ahead with the surgery. Okay, Dr. Kamlesh's advice that we could have done a bronchoscopy before proceeding for the corrective surgery. Yes, and
History of mother underestimated.
yeah, probably mother did give us a history of noisy breathing, but he never that the history was positive, yes, but then we didn't think it was like which is why an ENT evaluation was done outside. But he didn't look very bad actually on the day before the surgery. Yeah, and the tracheal tag, we thought, like, because of the shunt flow being more, we do see it quite often with a lot of our babies. So we thought this might just be one of it. We underestimated the problem definitely. So I'm going ahead to the next question. So what would have you done?
So he suggested he'll do HRCT or a bronchoscopy as such by Dr. Jigar. Yes, Dr. Jigar, it is like, but it will again add up to the cost also. And most of the patients we get like this and with the tracheal tag.
So in this particular patient, an ENT evaluation has been done in a peripheral hospital, and it was found to have a normal study. So since the resources were limited and we were seriously resource constrained, we couldn't actually go ahead with a detailed evaluation earlier. And since the baby was overtly symptomatic, we decided to go ahead with the surgery, considering that it's a simple VSD closure.
Yeah, Dr. Shankar has suggested that baby was already in OR, intubated, should go ahead with surgery and try to extubate if couldn't, and try bronchial dilatation later. This is a suggestion from Shankar Kadam.
Okay, so we've got a couple of suggestions and possible different things that the different anesthetists would have done. So I would like to tell you as to how we proceeded with the current situation. So what we did was we had a multidisciplinary meeting with the members of the pediatric cardiac team, which includes the pediatric cardiac surgeon, the pediatric cardiac anesthetist, the pediatric cardiologist, and the ENT surgeon as well. And we decided to defer the surgery for detailed evaluation at the current on that particular day. So we extubated the baby on table onto nasal CPAP, and he was transferred to our postoperative ICU. He did not have a very smooth stay. He had severe stridor. We had to optimize him. We had to continue nasal CPAP support for almost a week, and he stayed with us in the ICU for almost 10 days. And once he was stabilized, we did a CT chest, which showed an 8 mm long bitracheal stenosis and a tracheal bronchus, which took away from above the trachea, around 3 mm above the trachea, and also an associated left bronchus stenosis. So this is the view showing the mid-tracheal stenosis, and this is the 3D reconstructed picture, which shows the mid-tracheal stenosis, the tracheal bronchus, as well as the left bronchus stenosis. So the challenges we faced in this particular baby was that he had airway stenosis at multiple levels. He had failure to thrive. He had an uncorrected VSD, and he had a persisting stridor which required non-invasive ventilation for a long time, which eventually got better. So the question I have for the viewers is, what should be the plan for this child? How will you plan it out? I would want to hear the inputs of all of you, and then we'll tell you how we planned, what our plan was.
Corrective surgery. Jigar says corrective surgery.
Okay. Dr. Jigar has opined that we should have done a corrective surgery with tracheal reconstruction. Okay. The reason. Okay. Any other opinions from anybody else? Like what should be the plan, and how will you go about it? This, considering there are multiple problems. Okay. Yeah. So the the particular problem that we faced in this particular child, and why we did not go for tracheal reconstructive surgery at this in this particular admission, is because he had a distal bronchus involvement of the left, and this it was surgically very challenging, and we didn't have an invasive pulmonary intervention possible for such a small child. And tracheal stenting, yes, and so we can yeah, tracheal stenting was a possibility, but no, it was not possible for us because there was a supernumerary bronchus in this child. Yes, yeah. So the multiple problems here, again, I'm just repeating, is that the mid-tracheal stenosis as well as a distal airway stenosis, which made it very difficult for us to decide as to what to do. So I will.
Kamlesh is saying he's not
Okay.
in a view of having a tracheal surgery
With
along
the-
with the cardiac surgery.
Okay. But if you just went ahead with the cardiac surgery with a compromised airway like this, we were not looking at sending the child home anytime soon. So we decided.
Shankar has suggested that tracheal dilatation after the
We'll stay closer symptom, yes. But again, it's a long segment stenosis. Tracheal dilatation probably might not be very effective. Plus, there's a distal. The problem here was that there's a distal left bronchus stenosis, which we didn't really have a solution for at that time. The baby was only 3.2 kgs, 3.6 kgs, and we just didn't know what to do. So I would like to go ahead with what we did. So again, we had a discussion with we had a multidisciplinary discussion here with the pediatric members of the pediatric cardiac team, the ENT specialist, and as well as we involved the child's parents. And we decided not to do the surgery in this admission. We decided to continue nutritional rehabilitation, which the child was in need of, and continue to medically manage the cardiac failure, and to reassess the child's airway after 2 months. And it was all agreed upon, and we were hoping that the distal stenosis he would probably grow out of it, so we will have only one place of stenosis to deal with next time he comes. So the second admission was when the baby was 8 months of age. So this time he was readmitted for airway assessment and VSD closure possible. So on examination again, Miles Strider was there. He was on NG feed, but the positive thing was that he gained weight. He gained 1 kg weight, and tracheal tug was present, but otherwise he was looking alert. He was a playful child, and he was planned for an elective preoperative CT scan for airway evaluation. So in the 2019 December CT, this is a 3D reconstructed image on the left side and the 2D on the right. So it shows a mid-tracheal stenosis, which is still persisting. It's almost the same length, and the tracheal bronchus giving off about the carina. But as you can see, the left tracheal bronchus stenosis is definitely better and didn't really require an intervention according to these images. So comparing the CT of August 2019 and December 2019, you can actually make out the difference in the distal, that is the left bronchial stenosis, which looks way better after 2 months. And baby has definitely put on weight, and he's a better candidate now. So after the second admission, we decided to go ahead with the VSD closure and slide tracheoplasty. So the things which we thought made the present situation more favorable for surgery for both like VSD and the slide tracheoplasty concomitantly is that we had only the mid-tracheal stenosis to address, and the left main bronchus stenosis dimensions were better and didn't really require an addressing at this time, and the baby had gained weight. So this time on the day of surgery, we intubated the baby with a 3.5 mm uncuffed tube uneventfully fixed at 9 centimeters at the angle of the mouth. We went on pump and we extubated the child. ET tube was removed from the child, and the area of tracheal stenosis, the starting point of stenosis, was marked with the help of a bronchoscope, and VSD was closed first and slide tracheoplasty was done later. So I'm going to play a video of the intraoperative bronchoscopy which is done. It is not a very great video because it was just shot offhand, but you can make out the bronchial stenosis, the tracheal stenosis in this. Okay, so I hope you're able to see that. that was the complete rings and the stenosed part of the trachea. This is a bit of the clip of the dissection that was being done during the surgery. That is a cut open trachea that you're seeing, and the posterior part of trachea being dissected. So a little bit about what slide tracheoplasty procedure is about is that in case of a long segment tracheal stenosis and complete rings, the surgery is being is by incising the trachea in the mid tracheal point and sliding the upper and the lower part of the trachea over each other after placing an incision on the upper and the lower part of the upper and the lower segment. I mean, it's very clear in the picture. I think I confused it. Okay, so finally, after the correction, we have a shorter trachea, but with a wider diameter, almost double the size of what it was. So, and something about the dissection part, they dissect mostly anteriorly and posteriorly and avoid complete circumferential dissection not to disturb the vascular bed, as well as the other nerves that are susceptible to injury during this dissection is the recurrent laryngeal nerve as well as the phrenic. So, postoperative complications that can be anticipated are due to all these. And vascular bed disruption can lead to long-term complications such as necrosis of the trachea. So this is a very crucial part, and this was specifically said by the surgeon as to be careful during dissection. So going ahead with the actual challenge that we faced. So the surgery, after the slide tracheoplasty was done, our challenge was to reintroduce the endotracheal tube after the tracheal reconstruction, which we actually struggled with because this is the second case that we're doing of the same kind, and we're still in the learning phase. And things as simple as drapes fixation was are things we're still learning. So it was fixed in such a way that we were not really able to hold the laryngoscope handle. So we could not intubate the baby traditionally in the usual way. The airway was completely flooded with blood. And actually, before attempting the laryngoscope, we did try the endoscope, bronchoscope, and we couldn't really see anything because the airway was flooded with blood despite repeated suctioning. So, but finally, we were able to intubate nasally with a 2.8 mm bronchoscope, over which we railroaded a 4 mm uncuffed tube. And at this point, I would like to have opinions from all of you. What do you think could have been done differently to make our work easier over here? Opinions, and if you've done a similar surgery, what have you done to make it easier? Because we really struggled at this point. Okay, so is there any comments from listeners? Okay, so what we think could have been done differently is, one is that we could have placed the endotracheal tube at the cricoid level and not taken the tube out entirely. So we would have just had to push in, and before the complete closure of the trachea, the surgeon could have helped us guide the tip of the endotracheal tube past the anastomotic site, so that the injury to the anastomotic site is avoided. And another suggestion we got from one of our senior anesthetists is that we could have put in a pediatric urethral stent, which could have been just put in situ, and they could have done the surgery over it, and we could have railroaded an endotracheal tube. So. Oh, okay. Yeah. That was one suggestion, to keep the tube inside, but so that it doesn't come into the surgical field, but just at the tip of cricoid is also recommended, and we should have done that. Yeah, correct. Thank you, Dr. Vasu. So we're going ahead with the presentation. So there are specific postoperative considerations for a baby who's undergone slight tracheoplasty other than the OUSD concerns. One is the maintaining a flexion of the head is no more recommended. They're saying the maintaining neutral position is enough. Okay. Okay, ma'am. Yeah. Thank you, ma'am. Yeah, we would leave. Yeah, yes, ma'am. Okay. So, maintaining neutral position of the head and adequate humidification is important. It has been found to be very important to reduce the granulation formation. And early extubation is recommended, and adequate analgesia. And another important thing about postoperative consideration is that while toileting the ET tube, which needs to be toileted and kept clear of secretions, because if it gets blocked, then reintroducing is going to be a challenge. So ET tube suctioning should be done cautiously so that the tip of the suction catheter doesn't cross the tip of your ET tube, and the length of the catheter could be marked so that we don't disrupt or injure the anastomotic site. And in case the baby is extubated and you want to reintubate, it is recommended not to do blind instrumentation and should always be under bronchoscopic guidance. So specific postoperative complications where we are expecting. Yeah, yes, ma'am. Yeah, that's one complication that we can. Oh, okay. Okay, yes, ma'am. We can enjoy the tracheal repair during toilet. Yes, yes, ma'am. Yeah. Yeah, that is why now there was a recent update in tracheal surgery, and there was a conference in Coimbatore which happened last week, in which the surgeon has said that it's no more. They're okay with neutral position, and they just said to maintain neutral position of the head and not to hyperextend. That's all, and the flexion is not necessarily required, is what the surgeon said. So the specific postoperative complications associated with tracheal reconstructive surgery possible are anastomotic leak, pneumothorax, rectolaryngeal nerve injury, reflux, or silent aspiration. So going on to our baby and his postoperative course, he was electively ventilated for 48 hours, extubated on postoperative day 2 onto nasal CPAP, and he was transitioned slowly to high-flow nasal cannula, slowly weaned off. He was continued on NG feeds for at least 2 weeks, started very slowly on oral feeds, and on discharge, he was feeding completely on oral feeds, and he was doing well. So I made it sound extremely simple, but it was a lot of work and a lot of okay. How how early his extubation is as early as possible, but on table probably is not recommended. We gave the child 48 hours because there was concern from the surgeon as well, and that is why. So as soon as he was fully awake in 48 hours, we extubated him on POD2. And he stayed for 3 weeks with us, around 12 days in the ICU, and the rest of it in the ward.
Antibiotic?
Yeah.
What antibiotic?
No, we just gave a first line. We just gave a standard first line antibiotic cover, which is cefuroxime for us. Yes, which is cefuroxime for us, and it's continued to 48 hours, 8-hourly. That's all. Yeah. So and the one particular consideration for this baby and why we ventilated for 48 hours is because he went on pump, and we were expecting a little more of air edema than usual, so gave it some time to settle. That's all. So these would be the take-home message from our experience. One is that if we have a suspicion of a major airway anomaly, and we feel that there is a need to evaluate it prior to cardiac surgery, it's recommended that we do a detailed evaluation and take a decision, and a multidisciplinary collaboration is definitely required, and involve all the experts of the specialty to make a plan for such patients. Thank you.
So there are a couple of questions, and one of the question is from Kishore from Hyderabad. He is asking whether we did a check bronchoscopy after a week.
Yeah, we did a check bronchoscopy after 10 days, after 10 days of surgery. Yes.
And was there any steroid use?
No. No, we didn't.
After the surgery?
No. No, we have a routine in our ICU to be giving dexamethasone at a dose of 0.25 milligram per kg before extubation for all babies. That was the only thing that was given to the child and nothing else. Any questions or queries or something that you want to add to something that we have done? No. No, it was a conventional. We ventilated just like how we would ventilate any other baby for the child.
One more question from Nilesh, whether the
Okay.
ET tube tip was kept proximal or distal to the anastomosis?
We would keep the ET tube tip distal to the crusty and anastomosis and distal to it. 48 hours because there was a surgical concern. There was a surgeon's concern about 48 hours also. Except mortality. Around 2% would be, but there's a lot of morbidity though. Except mortality probably is almost equal to the CHD, maybe 2%. Role of microcuff tubes, we didn't put a cuffed tube because we put in an uncuffed tube. Yeah. We used an uncuffed tube, and I think for most tracheal surgeries for children, they recommend uncuffed tube. So even the leak test is probably possible. Yeah, bronchoscopy was done for our baby. Yeah.